Hi, I'm Dr. Anne Rimoin, and I have the greatest pleasure and honor of introducing one of my heroes and mentors, Dr. Joel Breman, for his presidential address at the American Society of Tropical Medicine and Hygiene this year. Joel is a giant in our field. He's one of the original field epidemiologists, a smallpox warrior, an Ebola discoverer, a monkeypox researcher, a malariologist, a CDC EIS officer, an NIH senior scientist, a WHO advisor, a husband, a dad, a grandfather, a mentor to many lucky health researchers and practitioners all over the world, and a champion of global health and tropical medicine. The few minutes I have to introduce Joel will never do justice to his very impressive career, but I'm going to do the best I can with the few minutes I have. Joel was born in 1936 in Chicago, and his family moved to Los Angeles in 1943. He spent his childhood here in Los Angeles, and in fact went on to go to the University of California, Los Angeles. He was always an athlete and played baseball as a teenager and rode varsity crew at UCLA while he was at university. Joel has always been a popular guy. In fact, he won most popular at Hamilton High School. And you can see he was just the same gregarious, friendly, and affable person that we all know and love today. What I found interesting while doing background on Joel's history was that he was actually not a traditional scientist, physician who majored in biology, was pre-med, and had a very straight path. Joel, in fact, was a political science major at UCLA, got what he liked to say were gentleman grades, and really was an athlete. It was only after he graduated, during some time in the military as an artillery officer, he decided that he was going to go back and pursue medicine instead. So he did what we now call a science year, went back, took the courses he needed, and applied to medical school. He went from being a Bruin at UCLA to a Trojan at the University of Southern California down the road. And he went to medical school, did his internship and his residency at LA County. His worst grades were actually in public health, but it was through his mentorship from Paul Worley, and the chief of pediatric infectious diseases at LA County, where he found great interest in infectious diseases. And that's how he started his career. Another important event in his life was during his residency when he met Vicki Ann Vaughn. Vicki was a nurse, and Joel was doing his residency. They met on Christmas Eve. They went on their first date on New Year's Eve. They were engaged by April and married by June. And they have been together ever since as a formidable team. Vicki and Joel have created a beautiful family, and I have had the very great pleasure of getting to know some of them. His son Matthew and his daughter Johanna are just as lovely as their parents, and were very eager to share photos with me and some anecdotes. I think the thing that struck me most with Joel was how many wonderful sayings he has and catchphrases. Matthew shared with me one of his favorites from his dad was when he would discuss management and leadership skills, he would say, "Only touch it once," meaning an email that you should immediately either respond to, delete, or file, but don't perseverate. Just do it, get it over with, be done with it. Only touch it once. Johanna shared her favorite Joelism, which was safety first, adventure a close second, which makes a lot of sense when you think about Joel's career. The other one they shared was laugh as much as possible. That's a great Joelism. And you can see how true that is with his relationship with Vicky. Johanna mentioned she sees her parents laughing all the time and tries to emulate that in life. I asked Johanna and Matthew to give me 5 words that describe Joel. Johanna said, calm, purposeful, positive, mischievous, best listener I ever met. Matthew said intellectual, sports-minded, health, principled, thoughtful, and lots of anecdotes. Another Joelism is cherish family, stay vertical. That is definitely something that that we can imagine him saying. And really, I think that this gets down to the basis of who Joel is. He's an incredible person who is so dedicated to his family and really gets what's important in life. In 1967, Joel left his internal medicine residency program at LA County to join the West and Central African Global Smallpox Eradication Program. He said he did it for 2 reasons. One, to see different health problems that he was seeing downtown in Los Angeles, and 2, adventure. Joel and Vicky went to Guinea, which had the 2nd highest rates of smallpox in the world at the time. And they lived there for several years. Guinea eliminated smallpox in 1969, and the disease was eliminated from the region in 1971. CDC offered him a Career Development Award, so he went on to the Harvard Channing Laboratory and Boston City Hospital, and then went on to London to learn more about malaria at the London School of Tropical Medicine and Hygiene. But he and Vicky missed Africa, so Joel wanted to return to learn more about tropical diseases and contribute. Joel was asked by the CDC to return to Africa to develop a surveillance program for smallpox and other communicable diseases. From 72 to 76, he worked in an 8-country Francophone health organization headquartered in Burkina Faso as the chief of the epidemiology section of the chief of the epidemiology section of the organization. There he focused on disease surveillance for cholera, yellow fever, smallpox, monkeypox, and other vaccine-preventable diseases. After 4 years in West Africa, the director of the CDC told him he'd been overseas for too long and he needed a domestic post. Vicky wanted to return to school, so they went to Michigan, where Joel was assigned as the Epidemic Intelligence Service Officer and state epidemiologist. He thought it would be a calm time and allow his wife and 2 young kids to reacclimate to the U.S. and find out about what health issues were important in the United States of America. Well, 1976 was a historic year for epidemics. Among other outbreaks, the swine influenza threat first appeared in the Midwest, and the U.S. government mounted the largest vaccination campaign in history to date. 42 million Americans were vaccinated, and Joel was responsible for the detection of the virus in the Michigan population and monitoring complications from the vaccination. Just as he was starting to get into his work on influenza, a call came from the CDC asking him if he would go to Zaire, now the Democratic Republic of the Congo. An epidemic of hemorrhagic fever was occurring in humans near a rural Catholic mission hospital. They asked if he could go just for a few days to figure out what was going on and report back. Well, that turned out to be the first investigation of Ebola hemorrhagic fever in the Democratic Republic of the Congo, Zaire. Joel was part of the international team that identified and described the disease caused by the new deadly virus, Ebola. Joel was with a great team, an international team, made great friendships and colleagues that have lasted through the years. David Heyman, also on this team, said, "I will always be grateful to Joel for his support, patience, and French language skills when we both worked in Francophone West Africa and elsewhere." His 5 words to describe Joel are diplomatic, competent, persistent, friendly, and patient. Peter Piot also was on this mission. Peter says, "I owe a lot to Joel, who really initiated me into field epidemiology and outbreak investigation when I was 27 and knew nothing. He combines unmatched experience with wisdom and a unique type of humor. He's a role model for generations and has made enormous contributions to global health." This photo here is of Joel with pipe, Peter Piot sitting next to him, actually doing work in the midst of this epidemic in 1976. Joel is featured prominently in leading books on the history of emerging infectious diseases. These include Laurie Garrett's The Coming Plague, Richard Preston's The Hot Zone. He always has a good story for people, and everyone wants to listen when he's speaking. Richard Preston said, and I quote, "I've interviewed Joel a half a dozen times over the years. I've always been struck by his fairness to colleagues and his humility about himself. I'm also, as a writer, impressed with his ability to tell a powerful human story in simple terms." He did several interviews with Joel for his most recent book, and he noted, "During one of those interviews, Joel gave me a description of what was going through his mind as he sat in the C-130 Hercules transport plane in 1976 with the international team on their first journey to Yambuku, Zaire." And he gave it straight from his notes. Joel said, "I was scared out of my wits. We didn't know what we were facing. We didn't know how it was spread or what we would see in the clinical picture. The concentration required an outbreak investigation so important here. We epidemiologists are the steeplejacks of medicine. We're the joiners. We're the people who pull together the steel girders of skyscrapers. Concentration is very important. You're focused on what you have to get done. We're like surgeons in the operating room." Richard went on to say, "I love Joel's honesty about being afraid. I experience a sense of thrill as I listen to his poetic and powerful description of the work of epidemiologists in a crisis. The steeplejacks of medicine. It's an unforgettable phrase." Richard went on to say, "Honestly, Joel Breman is one of my heroes in an age when it seems as not many people can be described as such." I asked Laurie Garrett, another very well-known infectious disease writer, what her thoughts were on Joel. She said her sentiments were exactly the same as Richard Preston's. And she also pointed out his humility, how humble he was, and the fact that he might understate his role in modern infectious disease analysis and prevention more than anyone else. Laurie advises us all, do yourself a favor, buy Joel a dinner, toss him a couple of leading questions, and sit back and savor the stories. After the Ebola investigation, Joel went back to Michigan, and expected to take up his work where he left off. But the CDC and WHO had other plans. In 1977, Joel became the deputy director of the Smallpox Eradication Unit at WHO. He was responsible for establishing safety standards and decreasing the number of laboratories with smallpox virus, describing human monkeypox in great detail, stopping the last smallpox outbreak that had reached Somalia from Ethiopia, and certifying the world free of smallpox. On May 8, 1980, the World Health Assembly declared the world free from smallpox. Joel and his family were there. In 1980, Joel and the family returned to CDC, and while Vicky worked on her law degree, Joel became a malariologist. There he spent 13 years studying the effectiveness of drugs on treating and preventing malaria in the field, along with looking at malaria and pregnancy and the effectiveness of insecticide-treated bed nets. During the 80s and early 90s, as chief of the malaria control activity, he quantified considerable burdens of malaria and led malaria research activities in 13 African countries as a part of a child survival initiative supported by the U.S. Agency for International Development, USAID. In 1993, Joel and Vicky moved to Washington, D.C. Joel became Associate Director of the National Vaccine Program Office in Washington, where he learned much about the way things work in Washington. He likes to sum it up as networking, diplomacy, and money are key. In 1995, Joel joined the Foege International Center at the NIH, where he established a research training program in emerging infectious diseases, linking scientists in the U.S. with those in low-resource countries to understand, define, and better control local health issues. At the time he arrived, the only research program they had focused on was HIV/AIDS. Today, they have many extramural programs working in over 100 low-resource countries. Since that time, the Foege International Center has trained over 6,000 scientists. Building partnerships from NIH and around the world has been extremely gratifying and productive for Joel. During this time at NIH, he also started an initiative on fraudulent drugs because of the problem of artemisinin resistance, and found it to be a much larger and more significant issue than just malarial drugs. They found that a third of all anti-malarials in Southeast Asia and Sub-Saharan Africa were falsified. Now, no active pharmaceutical agreement in any compound. During this time, he also served as the chair of the WHO Technical Advisory Group on Human Monkeypox and the chair of the WHO International Commission for the Certification of Dracunculiasis, guinea worm eradication. He authored many papers, he mentored many people, and he left his mark. Ken Bridboard said, "I feel most privileged to have worked with Joel throughout his career while at Foege." Roger Glass commented, "He's one awesome researcher and sleuth." Joel is an amazing star and guru of tropical medicine with a legacy that spans from eradication of the smallpox eradication program to the discovery of Ebola and the lead for the guinea worm verification of eradication team. At every stage, he's advanced the goals of global health while training a generation of public health professionals as an outstanding mentor. His legacy of contributions to tropical medicine and global health is outstanding, and we are proud to have him at Foege for the past 3 decades. He's a gem. Although Joel officially retired from federal service in 2010, he has continued to collaborate with the Foege International Center as an honorary senior scientist emeritus on epidemiologic research defining the burden of malaria and pervasiveness of poor quality of drugs. In his spare time, he also continues to teach at the George Washington University, mentor scientists, consults for WHO, the Carter Center, the Gates Foundation, USAID, FDA, and the multilateral initiative on malaria. He continues his work as co-chair of the WHO International Commission for the Certification of Dracunculiasis Eradication, and is a chair of an ad hoc group planning the celebration of the 40th anniversary since the World Health Assembly confirmed the eradication of smallpox, which should have been happening right now. As somebody who has benefited from Joel's mentorship over the years, I do want to highlight how important he has been for my career, but for a whole host of other people. He has really been an incredible mentor and a source of support and resource of wisdom for so many of us global health researchers. Chelsea Hansen, one of his students, says, "Even though he has hundreds of students, it was always important to him that he remember each and every one after the course was over. And as a teacher and a mentor, I would describe him as inspirational, dedicated, supportive, curious, and humble. Yassim Tozan, another one of his mentors, comments, "Everyone here knows what a giant Joel is in the field of global health and has tremendous respect for him. What's also true of Joel is that he has affected many of us in ways that go far beyond our professional lives and close to our hearts. Joel is unconditionally kind, perceptive, humble, and gracious. He is singular in his capacity to enjoy the success of those he has nurtured and championed." And that's the truth. This set of photos here just shows how much joy Joel takes in bringing people together and celebrating life. These photos are from many Trop Med dinners over the years, and Yassim's wedding, where he managed to uncork many bottles of champagne. There were so many people that wanted to weigh in on the incredible influence Joel's had. So I asked people just to give me 5 words to describe Joel. And so here I've compiled a list of the ones that most commonly came up. Intellectual, health, principled, thoughtful, compassionate, insightful, open-minded, dedicated, charming, honest, collegial, kind, warm, wise, brilliant, analytic, humble, integrity, modest, hero, historical, ageless, scholar, defender, dedicated, and fearless. I even got Dr. Tony Fauci to give me 5 words for Joel. His words were brilliant, modest, humble, warm, and honest. So there you have it. Joel Breman is so many things: a scientist, a public health hero, a mentor, a family man, and a friend to many. He's made an indelible mark on public health nationally and internationally. He is a towering figure, one of the great generation of emerging infectious disease detectives and responders. He's a true field epidemiologist. He's been a champion of global health and tropical medicine. We've been so lucky at the American Society of Tropical Medicine and Hygiene to have his great leadership and his passion and compassion during such a tumultuous time in history. Another one of Joel's famous sayings is, "Expect the unexpected." Well, Joel, we can't wait to see what you surprise us with next. But in the interim, thank you for your leadership. We are all grateful for what you have done and continue to do for the society, and we can't wait to see what's next.
Thank you, Annie, for those kind comments. I can assure those tuned in that some of those stories are true, and I am proof that there is no age discrimination in the American Society of Tropical Medicine and Hygiene. The Society has been my main professional home for 5 decades. This year has been like no other in our history. The COVID-19 pandemic has challenged us in every way. We have responded to the assaults on science through writing for our journal and for other journals, for joining like-minded societies with statements to the press and appealing directly to decision makers here and abroad. Advocacy for global health research and control programs in poor countries has been led by our CEO, Karen Goralewski. She, with our great staff and partners, have been performing miracles. Thanks, Team Trop Med. And a big thanks to our board of directors who set the standards high and are major advocates for what we do. The biggest challenge has been to have this virtual meeting. I thank Dan Bausch, Stephanie Yano, and Lynn Maddox for this feat, plus those understanding folks in Toronto whom we hope to see in the future. Most dear to me is my family. My wife, Vicki, nurse, lawyer, chaplain, house manager, and fellow traveler, has had good reason to serve me with divorce papers for frequent abandonment. She hasn't, yet. My son Matthew and daughter Johanna and their spouses Rachel and Tomer are also stars with rich international histories and horizons. Thanks to them for constant support and guidance, and for their wisdom in raising kind, curious, and generous children of their own. Now for the main event. First, I would like all those who have worked on and supported the smallpox eradication program to stand. Wherever you are the heroes I honor today, who were celebrated yesterday in the Smallpox Symposium and mentioned by Dr. Tedros in his opening remarks. 2020 marks 40 years since the World Health Assembly accepted the 1979 conclusion of the Global Commission for the Certification of Smallpox Eradication that the dread disease had been eradicated. It is fitting that we reflect on the history and conduct of the eradication program, focusing on Africa. Not only is Africa where the first and last cases of the disease were recorded, but where some of the unique control and eradication strategies and tactics were discovered and deployed. The control of the COVID-19 pandemic will be dependent on many of the principles and practices used in smallpox eradication, another reason to examine our past. Pharaoh Ramses V died in 1157 BCE. He has the dubious distinction of being the first known patient with smallpox caused by variola virus. His mummified face had a set of pustules when the corpse was unwrapped and photographed in the early 1900s. Variola needs a critical number of humans to continue circulating, as there is no non-human reservoir of smallpox. The Fertile Crescent between the Tigris and Euphrates rivers was one of the most dense population centers in the world before the time of Christ, the others being in the Ganges River basin in the Indian subcontinent and between the Yellow and Yangtze rivers in present-day China. Over the next 1,800 years, the disease remained in these population-dense areas, since smaller towns and hamlets could not sustain continual interhuman transmission. About 700 CE, with the rise of Islam in the Middle East and the spread of religion and trade across North Africa and south into sub-Saharan Africa, smallpox and other diseases took hold. Over the next several hundred years, the great African kingdoms prospered. They fostered great art, architecture, and political stability. Here is a graphic showing what may have been smallpox lesions from a statue in Mali dated the 13th century. By the late 1400s and well into the 1800s, the European powers arrived and established territorial extensions of their own kingdoms. First Portugal, then France, Belgium, Britain, Germany, and Spain. This influence lasts to this day. The colonizers were clear in their goals: to establish outposts for expediting their commercial interest. This included subjugating the locals, often by a divide and conquer strategy. Divisions of territory were made geographically in Europe, often without great attention to ethnic boundaries. The expatriate communities concentrated along the coastlines in the capitals and in other large cities. These areas benefited preferentially from public health measures, which, beginning in the late 1800s, included vaccination against smallpox, with only partially effective liquid vaccines. During the colonial period, the foreign military served as medical and public health supervisors. Civil servants and military officers trained in tropical diseases in Lisbon, Antwerp, London, Marseille, and Bordeaux. They provided the leadership and staffing of rural outposts. It was soon found that these isolated rural populations were afflicted with many medical conditions requiring attention. Sleeping sickness in the Congo Basin and other areas of southern Africa stimulated the great campaigns against sleeping sickness. These were first led by Eugene Jameau of France, which started in the Cameroons in the 1920s and slowly went north, village by village. Jameau trained illiterate microscopists to look for trypanosomes in the tissue taken from nodules in the necks or from cerebrospinal fluid of suspected patients with sleeping sickness. They also saw much smallpox. Similar mobile teams were deployed in Anglophone West Africa, focusing also on onchocerciasis, schistosomiasis, and leprosy, while also giving smallpox vaccinations. The liquid smallpox vaccine used was not heat stable. Vaccine success rates reflected by pustules on the arm after vaccination were often below 50%. Despite hundreds of thousands of smallpox vaccinations given in West and Central Africa, many more than the census population numbers, periodic epidemics of smallpox raged in Africa. The real numbers were 10 to 100 times higher than those reported because of incomplete surveillance. In 1948, the World Health Organization was formed with altruistic goals to develop health policies, establish disease surveillance systems, and promote control and elimination programs, of which malaria control, relying on DDT use, was the most prominent activity. In 1959, the Soviet delegation introduced a resolution for a smallpox eradication program to the World Health Assembly. For the next 8 years, little progress was made. Few staff and funds came to WHO for smallpox work. In 1967, an intensified eradication program began after another smallpox eradication resolution was endorsed by the Assembly. About then, U.S. President Lyndon Johnson supported the global smallpox eradication effort in West and Central Africa as part of the global program. WHO requested that the director of the global program come from the U.S., the country that had raised the resolution for an intensified program. D.A. Henderson of the CDC was chosen to go as leader of the smallpox eradication unit. In 1967, one of the first things done within the smallpox unit in Geneva was to look at the quality of vaccine being used by countries. It was found then that only 10% of the laboratories producing smallpox vaccines met standards for potency, stability, and purity. 2 reference laboratories, Connaught in laboratory and the Rijksinstituut in the Netherlands, tested products from 59 vaccine manufacturers. 7 countries of the 20 in the West and Central African program were among those with the highest incidence of smallpox in the world. Measles vaccine had been developed in the U.S. in the early 1960s at Merck, and the Minister of Health of Burkina Faso, then Upper Volta, visited the U.S. in the 1960s and invited the U.S. government to test the feasibility of deployment of this vaccine in West Africa. After 2 years of field technology testing by CDC staff, supported by the U.S. Agency for International Development, and country negotiation, the West and Central African smallpox measles program was conceived and implemented. I lived in Guinea for 2 years and Burkina Faso for another 4 years during this program, and then in Geneva working on the final phases of eradication from 1977 to 1980. Several scientific, technical, and managerial innovations led to the success of this program. Both smallpox and measles vaccines were sent from the manufacturers to the field in heat-stable, freeze-dried powder along with diluent. The Petojet injector gun was used to inject the vaccine directly into the skin. An intradermal nozzle was used for smallpox vaccine and a subcutaneous nozzle for measles. All persons were given smallpox vaccine, as all were at risk. Children from 6 months to 5 years were given measles vaccine. In Guinea, each team averaged 2,000 persons a day per team over 2 years during the vaccination program. The Petojet was effective when large numbers of persons could be assembled, as in Brazil and West and Central Africa. Toward the end of the West and Central African program, the bifurcated needle was introduced into all of Africa and the endemic countries. This modification of a sewing machine needle allowed a drop of the vaccine to be caught between the prongs when dipped into the vaccine bottle. This allowed a great savings in vaccine, and the procedure could be taught in a few minutes to virtually anyone, and the needles sterilized easily at night. The success rates were over 95%. The strategy when the West and Central African program began was to vaccinate at least 80% of the population, the original goal of the global program. It was believed that this level of coverage could result in herd immunity. However, during the vaccine shortage in eastern Nigeria in 1967 and 68, during the Biafran Civil War, a CD contract missionary, Bill Foege, examining a patient in this slide, a former EIS officer, vaccinated only family members and close contacts of patients with smallpox. Other contacts at risk were vaccinated and put under surveillance. The cluster of outbreaks in eastern Nigeria completely melted. The approach became known as selective ring vaccination and surveillance containment. Emphasis was now put on aggressively finding every case of smallpox and stopping its spread. Epidemiological indices were used to find and contain cases, particularly seasonality. When the number of outbreaks and cases was lowest during the rainy season, this proved the best time to go to areas of high suspicion. Mass vaccination continued, but resources and publicity were now aimed towards surveillance and containment. An early track, trace, and cross-notification strategy was used. The last smallpox case was detected in Nigeria in May 1970. Supportive laboratory diagnosis and orthopoxvirus research was built into the program from an early stage, at first focusing on vaccine quality, but later on diagnostic conundrums. In May 1971, a patient with a typical smallpox-like eruption was detected in the Democratic Republic of Congo, then Zaire, 10 months after the last smallpox case had occurred. WHO poxvirus collaborating laboratories in Moscow and Atlanta confirmed the diagnosis as monkeypox virus, an agent that had been the cause of outbreaks in animals in North American and European zoos. Over the next decade, several countries in West and Central Africa reported cases of human monkeypox. This newly detected disease in humans did not appear to transmit avidly from person to person. Smallpox vaccine protects against monkeypox, but immunity has waned since vaccination stopped in 1982 globally after eradication. Few longitudinal ecologic studies of monkeypox have occurred. One rope squirrel with an eruption was found near a monkeypox outbreak, yet the natural history of the disease remains to be clarified. Several recent large outbreaks of human monkeypox have been reported in Nigeria and the DRC, as we heard at the Smallpox Symposium yesterday. We are now facing the decision on whether smallpox vaccine should again be used in areas where monkeypox is endemic. The use of operations officers, managerial experts, was a major innovation in the West and Central African program. These persons were conversant with logistics, communications, transport, personnel, equipment, and especially proper storage and use of vaccines. Management with surveillance were the keys to eradication. Knowing what works and what doesn't work in a timely, regular manner is now accepted by public health programs since smallpox. The WHO weekly epidemiological report was used to transmit information on progress in each program. And the CDC had their own summary for the West and Central African program, including progress in measles activities. The best ideas throughout the program came from the field, not from headquarters. These were village-by-village searches for cases, feeding patients in their homes under guard, smallpox identification cards for searching in schools, villages, and camps, screening at festivals and pilgrimages, including the massive number going to the annual visit to Mecca. Smallpox rumor registries were assembled. A monetary reward for reporting confirmed smallpox cases was used. Detailed protocols for reporting and investigating cases. Having petty cash funds in the hands of field workers to hire local searchers and guards. Moving staff from country to country when the political winds changed, as occurred between Ethiopia and Somalia in the mid-1970s. And then using Peace Corps volunteers from the US, Japan, and elsewhere as researchers house to house and field supervisor. While the West and Central African program was maturing, great progress was being made elsewhere. In the Americas, only Brazil and Argentina had disease. They were the first continent to be certified smallpox-free by an independent commission. The major challenges remain with the Indian subcontinent and Eastern Africa. The biggest hurdle in India was convincing national and state health authorities that the surveillance containment approach, track, trace, isolate, vaccinate, report, and cross-notify, was more effective than mass vaccination done slavishly. Village searches turned up thousands of outbreaks that had been unknown or unrecorded. At one time, we had over 150,000 field workers in India alone, hunting smallpox door to door. A detailed containment protocol for use at the local level was used. The last outbreak in the world occurred in Ethiopia and then Somalia in 1976 and 1977. Countries that were at war over land. Cases were occurring among nomads in the Ogaden Desert and then moved from Ethiopia into Somalia. Before containment occurred, over 3,000 cases were identified and contained. The last naturally transmitted case occurred in Merka, coastal Somalia, on October 26, 1977. Here we have pictures of the last persons with naturally transmitted disease. Rahima Banu in Bangladesh in 1975 with variola major, and Ali Mao Malan in Somalia in 1977 with variola minor. There are many differences between COVID and smallpox. Coronaviruses are RNA viruses, but appear to have limited ability to mutate. This facilitates tracking the geographic spread. 7 coronaviruses are known to cause human disease. SARS-CoV-2 is believed to come from an animal, perhaps a bat virus transferred to another animal, then was spillover to humans. While there are many orthopox viruses, variola, a DNA virus, is classified into major and minor. The major differences are in their clinical and epidemiological presentation. There are public health lessons from smallpox that should be applied to public health control. The incubation period for COVID appears to be 5 to 10 days and is 7 to 17 days for smallpox. Both are respiratory diseases transmitted mainly by large droplets. Important is the secondary attack rate among susceptibles. This is represented as the R0. For COVID-19, we are now seeing about 2 to 3, and for smallpox, this may be 3 to 6, compared with about 12 for unvaccinated persons with measles. There was no smallpox spread from asymptomatic persons to those in the incubation period. COVID does transmit during the incubation period. Both conditions now have FDA-approved treatments. During the program, we had no specific treatment for smallpox. With the specter of bioterrorism for smallpox, tecovirimat was recently approved by the FDA, but has never been used for a smallpox patient. Remdesivir is approved for COVID-19, but only shortens clinical illness, not mortality. Most importantly, for smallpox, we had strong central leadership at WHO applying a public health model with flexibility to change the model when new evidence accrued. We had a detailed operational plan. Each country adopted the plan based on local conditions. The new containment strategy was central to the plan. High-quality vaccine, other supplies, and equipment usually came through a supply chain that was centrally managed carefully. Personnel from over 70 countries worked as international civil servants, leaders in endemic countries serving the goals of the eradication program rather than their own national agendas. Without this leadership and clarity, the program would have failed. The importance of international cooperation must be emphasized. In closing, let me return to African innovations for COVID-19 control. These control measures, initiated by African countries, have muted the spread, particularly the rigorous implementation of case tracking, along with other mitigation measures. Nigeria, Uganda, Rwanda, and South Africa, among others, have developed highly successful methods in finding case contacts, testing them, and taking measures to limit spread if they are positive. These countries had extensive experience establishing tracking systems for the Ebola outbreaks that have hit Africa since 1976, and also for polio, Lassa fever, guinea worm, HIV/AIDS, and measles outbreaks. The innovations applied in Africa first resulted in the eradication of smallpox. Those being developed by African countries today will help us control COVID and other perils that are percolating now and will certainly face us in the future. Thank you.